Dear colleagues, dear friends, welcome to this global symposium, Why Flu Vaccinations Matter, organized by the International Pharmaceutical Federation, FIP. It's indeed a great honor and pleasure to see so many participants from all over the world attending today's symposium. Next slide, please. My name is Lars-Åke Söderlund, and I have the honor and great pleasure of moderating this event today. Next slide, please. For those who don't know me, I am one of the vice presidents of FIP, and on a daily basis, I work as an executive advisor for Apoteket, a government-owned pharmacy chain in Sweden. And apart from this, I have some other assignments within FIP as well, as you can see on this slide. Next slide, please. The threat of the pandemic influenza is real. And as the Director General of the WHO, Dr. Tedros Ghebreyesus stated, the threat of pandemic influenza is ever present. The ongoing risk of the new influenza virus transmitting from animals to humans and potentially causing a pandemic is real. The question is not if we will have another pandemic, but when. So we must be vigilant and prepared. The cost of a major influenza outbreak will far outweigh the price of prevention. Vaccination is one of the most effective ways to prevent infection and severe outcomes caused by the influenza virus. Development and production of influenza vaccines, planning for their supplies, and use as well as provision of other respective healthcare resources are essential components of a comprehensive seasonal and pandemic influenza response. Next slide, please. When 100 passengers on a flight from Dubai to New York in September 2018 fell ill with respiratory symptoms, health officials were concerned that they might be carrying a very serious respiratory illness called Middle East Respiratory Syndrome coronavirus and quarantined the whole airplane until further health checks could be completed. And testing showed that several were positive for the influenza virus, which can be easily spread when people are in close contact with each other or in contained spaces such as airports and planes for several hours. Influenza may not always be thought of by most people as a serious illness. The symptoms of headaches, runny nose, cough, and muscle pain can make people confuse it with a heavy cold. Yet seasonal influenza kills up to 650,000 people every year. And that is why influenza vaccinations are so important, especially to protect young children, older people, pregnant women, and people who have vulnerable immune systems. What most of us think of as the flu is seasonal influenza, so-called, because it comes around in the coldest season twice a year. Once in the northern hemisphere and once in the southern hemisphere, and especially in the winter season, and in temperate zones of the world, and circulates year-round in the tropics and subtropics. Next slide, please. The intensity and speed with which the 1918 influenza pandemic struck were almost unimaginable, infecting 1/3 or around 500 million people of the Earth's population. And by the time the pandemic subsided 2 years later, more than 50 million people are estimated to have died. And globally, the death toll eclipsed that of the First World War, which was around 17 million people. So there was actually nothing Spanish about the 1918 pandemic. While it already had taken a big toll in France and USA, it was not made public in those countries because of wartime censorship. French doctors even called it Maladie 11, or meaning disease 11. It was a special code. And when the disease surfaced in Spain, which was neutral during the war, the country had no censorship in place and so made the first public reports about the pandemic. The name stuck. Next slide, please. According to the World Heart Federation, influenza increases the risk of heart attack more than 10 times in the first 7 days after contracting the flu. And vaccination can actually reduce the risk of heart attacks up to 45%. Next slide, please. Next slide, please. The WHO has developed a global influenza strategy, and despite of a temporary drop in the incidence of seasonal influenza during the pandemic, it will certainly continue to represent a heavy burden for all healthcare systems and societies overall due to its impact on health, productivity, and quality of life. And this is especially worrying for vulnerable population groups, including the elderly. And in a post-pandemic scenario, it's crucial to protect and further advance the progress that had been achieved globally in terms of flu vaccination rates. So this digital and global symposium will discuss why flu vaccination remains a priority and how co-administration of flu and COVID-19 vaccines can provide a convenient and effective solution for driving vaccination uptake. The symposium will also explore how pharmacies can contribute to communicating the benefits of vaccination against flu and to administering these vaccines where possible. Next slide, please. Before we continue, let's go through some housekeeping rules. This webinar is recorded and live streamed via YouTube, and the recording will be available on our website, events.fip.org. And you may ask questions using the question box provided. Please use the Q&A box and not the chat box. And you are also most welcome to provide feedback to webinars at fip.org, because that means that we can even improve our future digital events, which is, of course, a benefit for you. And I also would like to advise you to become a member of FIP, because in this complex world with so many challenges for our healthcare systems, we need to remind ourselves that we are stronger together, sharing experiences and learning from each other. And after this symposium, all of you who are attending today will actually get a certificate from the event sent to you at your email address. Next slide, please. I would also like to thank the International Federation of Pharmaceutical Manufacturers and Associations for their kind, unrestricted fund supporting this online event. Thank you so very, very much. Next slide, please. So let's look into today's program. We have a number of extremely knowledgeable speakers with us today. We have Dr. Joshua Mott, Technical Officer, Influenza Preparedness and Response from the WHO. We have Dr. Lynn Morgan, Coordinator, Policy and Communications Group, Influenza Vaccines Supplies, the International Federation of Pharmaceutical Manufacturers Associations. And we have Mrs. Maria Mendez, Area Manager at the Center of Medicines, Information and Health Interventions at the National Association of Pharmacies in Portugal. Next slide, please. By the end of the session, by the end of the symposium, well, first, of course, today's program. Why do we need to keep vaccinating against the seasonal influenza? One health perspective presented by Dr. Joshua Mott, living with seasonal epidemics of influenza and COVID-19. What does coexistence mean and imply? From Dr. Lynn Morgan, and protecting and expanding pre-pandemic vaccination coverage rates for influenza, a case study from Portugal presented by Maria Mendez. And then we, of course, have the Q&A session where we invite you all to send your questions through the Q&A box at the bottom of the screen. Next slide, please. And the learning objectives for today's session is to understand the importance of flu vaccination, and especially for vulnerable population groups like the elderly, and recognize the need for improving vaccination coverage rates for both the flu and COVID-19, and discuss pharmacists' contribution to flu vaccination strategies. Next slide. By this, it is now my pleasure to introduce the first speaker, Dr. Joshua Mott. Dr. Mott is currently a technical advisor on influenza and preparedness to the WHO's Department of Epidemic and Pandemic Preparedness. Prior to his arrival to the WHO in April of 2022, he was the US Center for Disease Control, Southeast Asian Regional Influenza Program Director. In this capacity, he provided technical oversight and supervision to surveillance, preparedness, and policy-relevant work, not only in Thailand, but also through regional supervision in Laos, Indonesia, Myanmar, and Bangladesh. Dr. Mott also served as the CDC Influenza Program Director in Kenya. And from 2009 to 2011, he was also the Center for Disease Control Influenza Technical Advisor to the WHO Regional Office for Europe. And prior to working in influenza, Dr. Mott worked in the areas of biothreat agents, complex emergency field response, and the environmental health. He also served as the epidemiology lead for CDC Thailand response to the COVID-19 pandemic. Please, Dr. Mott, welcome to the floor. The stage is yours.
Thank you, Dr. Soderlund, and thank you everyone for having me here. It's an honor to be able to present to you on this important topic. I was asked to give a very quick overview of influenza viruses and the importance of vaccination, but not just as we think of it for seasonal human influenza, but also to make the connection to One Health and the importance of preparedness and how to send the message of how seasonal preparedness also keeps us ready for future pandemics. So a little bit of background. Seasonal influenza is a viral acute respiratory infection. And as many of you well know, it can be characterized with abrupt onset of fever, cough, sore throat, chills, myalgia, fatigue, and headache. There can be various presentation by age. The very old may be less likely to develop fevers, and there's in neonates and in the very young, more of a sepsis presentation for severe influenza as well. 4 influenza viruses circulate annually worldwide right now. There's 2 influenza type A viruses, as you hear about them, as H3N2 and H1N1. The H's and the N's signifying surface proteins, hemagglutinin and neuraminidase, that we'll talk a little bit more about in this talk. And there's 2 influenza type B lineages that circulate. There's B Victoria, and there's B Yamagata, though it's been much less in circulation and maybe phasing out by B Victoria more recently. The severity of infection varies from year to year from these viruses, and I'll explain more about why briefly. And in temperate regions, we get seasonal winter epidemics. And in tropical regions, we typically get more year-round activity, sometimes peaking in periods of rain or cooler temperatures. We have sporadic out-of-season outbreaks for influenza too, in institutionalized populations that are in closed settings, in particular in rural populations, in travelers and so forth. So influenza can even in seasonal temperate climates can be detected year-round. In terms of viral shedding and incubation period, something we've all been thinking a lot about in the last 2 years. Influenza viruses infect, replicate, and shed in the upper respiratory tract. The incubation period, which is the time from exposure to symptom onset, is typically 1 to 4 days. This is 1 to 4 days, but often can be shorter. It may depend on how much exposure one has had and other host issues. In terms of viral shedding in the contagious period, you can have viral shedding before illness onset, with peak shedding 1 to 2 days of illness, and the duration may be 4 to 6 days of viral shedding, or perhaps longer in children and those that are immune compromised. Influenza can cause the full spectrum of illness, and it certainly, as was pointed out in the introduction, can cause severe outcomes with a significant burden of disease globally. Risk factors for severe outcomes are being older, particularly over 80 years, but in the elderly, and infants under 6 months of age, who may have the benefit of being protected through vaccination of pregnant women who can pass antibodies on to their children, their unborn children. Those with chronic medical conditions, such as heart or lung disease, including asthma, metabolic diseases, including diabetes, HIV/AIDS, and other immunosuppression, and conditions that compromise respiratory function or the handling of respiratory secretions. Importantly, influenza can cause death in these populations, sometimes well after the virus can even be detected in that person. When one has metabolic diseases or cardiovascular diseases, the infection, the early on influenza infection can tip them out of balance, if you will, and cause them to have complications of their underlying medical conditions. They might fight this for a while and ultimately die associated with that influenza exposure, even if they are no longer shedding the virus and it can no longer be detected by PCR. That's why sometimes you will see that excess mortality associated with influenza can look quite dramatic in older populations because of this delayed effect, if you will, of some of those outcomes. Certain populations of indigenous peoples who have less access to care and less access to early respiratory management and medications and so forth are more hit globally by influenza every year. And pregnant women, those that are morbidly obese, and those in nursing homes are known to have higher risk for severe outcomes. So we talked a little bit already about the global annual impact of influenza, and you already heard anywhere from 300,000 to 650,000 deaths annually are estimated to occur from influenza each and every year, though it varies by the strains that are circulating and so forth. But that's just the tip of the iceberg, if you will. We're talking about 3 million to 5 million severe cases and hospitalizations, and over 1 billion cases of influenza occurring annually. And when you look toward the bottom of that pyramid, you think about the magnitude of economic costs and economic burden associated with the direct costs of care, but also the indirect costs of lost work and school time and the needs that come when caretakers are sick from influenza. So estimates of direct medical costs in US dollars of about $10.4 billion per year, and indirect and direct costs of $87 billion per year associated with influenza. That means the tools that are at hand for pharmacists and persons like you and the antivirals that we have can go a long way to preventing significant, not only health, but economic burden in our own countries. So the benefits of seasonal influenza vaccination are broad. Influenza vaccination is a critical part of influenza prevention and control strategies, which also include therapeutics and non-pharmaceutical public health and social measures. So vaccination can certainly reduce the burden of disease in terms of deaths, hospitalizations, transmission from one person to another, and can reduce work economic impacts associated with missed work days, as well as indirect costs. But seasonal influenza vaccination has the broader benefit of strengthening our health systems as well. Each and every year for respiratory diseases, we're strengthening our cold chain facilities, our trained staff to deliver medications and vaccinations, cost savings in terms of having routine systems in place and ready for emergencies, and integration with national pandemic preparedness operations. If you have a system that is working each and every year, we've seen in this pandemic and in past pandemics that those systems scale up more easily to reach needed populations with influenza vaccines or other vaccines in times of emergency. And that makes us better prepared, the systems for delivery, the regulatory pathways that must be put in place to implement a seasonal vaccination program, the operational capacity that's in place, and the awareness of the population to obtain vaccination, especially the adult population, for a respiratory disease is all improved prior to the next emergency. And so aside from preventing important burden of disease each and every year, these systems are essential for our future pandemic preparedness. The Strategic Advisory Group of experts convened by WHO updates influenza vaccination recommendations periodically, and they did so in a position paper in May 2022. In that position paper, all countries are recommended to consider implementing seasonal influenza vaccination programs for reasons that I've already said, with priority target groups being health workers, individuals with comorbidities and underlying conditions, older adults, and pregnant women, which fits the epidemiology that you've now seen. Children are also considered an important target population, and other groups to be considered are those living in congregate living settings, disadvantaged populations, and indigenous populations. Target groups should be driven by national burden priorities, resources, and programmatic feasibility. Very importantly, the recent recommendation comes out to say that co-administration of seasonal influenza vaccines and COVID-19 vaccines is acceptable and encouraged. You can see this is the percent of outpatient influenza-like illnesses testing positive for influenza in the United States, 2018-19, just before the current pandemic. And you can see previous seasons as well. What I want to show you is the important burden each and every year of seasonal influenza. If you look on the left, there's a light gray curve from the 2009 pandemic. And you can see there was a very significant burden of outpatient influenza-like illness cases being dealt with that year. And you can see that in many other years following the different colored lines, there was a lower burden, but a significant burden in each season. And then sometimes, even with seasonal influenza, you can have very severe seasons. For example, the 2017-18 season produced a burden of outpatient illness nearly rivaling that which we saw in the 2009 pandemic. That means it's not just pandemics that we're worried about, but the deaths and illness and economic burden that come each and every year that can be prevented by vaccination. And here's one example again from the US. Vaccine programs save lives every year. And these are estimates, it's hard to see, of the amount of burden prevented by vaccination estimated through the vaccination programs in the US. And uptake of the vaccination is not complete through the entire population, but even with what is achieved, you can see there's 64,000 hospitalizations prevented, another 2.6 million clinic visits, and 5.5 million influenza illnesses prevented, with a significant portion of prevention in children as well. But it's not something that's limited to high-income countries. And increasingly, lower and lower middle-income countries are undertaking their own cost-effectiveness of seasonal influenza vaccination programs around the world, and finding them to be an important economic benefit to them as well. Here's one example from recent work that's happened in Laos, where they found vaccination of healthcare workers to be highly cost-effective, and vaccination of their other target groups in Laos to be cost-effective using WHO cost-effectiveness standards. As a result, you can see that countries are starting to realize the importance of seasonal influenza vaccination. And as of 2018, 118 countries had seasonal influenza vaccination policies in place globally. Some of them have more or less penetration of actual vaccination with influenza vaccines, but you can see by the spread of policies that there's a growing realization that this is an important consideration for ministries of health, for both social health and economic well-being. So real quickly now, I want to talk about broader preparedness, but we have the seasonal influenza viruses, as I mentioned, have surface proteins, hemagglutinin and neuraminidase, and birds are the natural reservoir for all of the subtypes. There's a wide host range. Influenza can affect multiple species, including swine, horses, dogs, cats, whales, and other places, and it can jump species, and that's what makes it capable of causing it. It causes epidemics, and it makes it capable of pandemics. Every year, you can have variable severity of influenza seasons because of antigenic drift. The virus, to survive, continually maintains itself by acquiring new point mutations, and it avoids our immune systems, and the degree to which it can avoid our immune systems can equate to the severity of a seasonal epidemic. And that's why we have variable seasonal epidemics every year. And that's why we have to do constant surveillance to identify what is circulating, what mutations exist, and if we have to update the vaccines. And the North and the Southern Hemisphere have annual meetings to decide on the composition of global influenza vaccines. But more rarely, these viruses can mix together and acquire combined genes from animals and from human sources through reassortment. And this kind of antigenic shift is associated with pandemics that have happened in the past and will certainly happen again in the future. You can see that there's avian viruses and there's human viruses. And when we come together, there's always the potential for reassortment. That's why we do a lot of surveillance at the animal-human interface with One Health coordinated response to determine if novel viruses are infecting humans. There are certain animals that have receptor binding affinities that can allow for the binding of both human and avian viruses and animal viruses. Pigs are a good example of that. Inside a pig, these viruses can all bind and mix together and create reassortant viruses. And that's why you may hear in many places that there's swine influenza viruses that are of concern because they have reassortment capabilities and may have pandemic potential. What we're worried about is a virus that can take the human characteristics of transmission between humans, but have other pathogenicity characteristics that make the disease more severe in humans to which we have no natural immunity. If you have both of those together, it can cause a potentially severe pandemic. That's what we've seen with coronaviruses, and that's what we've seen with influenza viruses in the past. So influenza pandemics occur when there's a new subtype in humans, there's little or no immunity in the population, and it's easily transmitted from person to person. In the 20th century, in the 21st century, we've seen them in 1918, a severe one, a moderate one in 1957, and in 1968, and then thankfully somewhat of a less severe one in 2009. And this is a part of the natural evolution of influenza viruses. Every virus that is seasonally circulating now started as a pandemic. In 1918, we had a severe influenza pandemic causing widespread morbidity and mortality. And that H1N1 virus emerged and circulated until 1957, when H2N2 emerged in Asia and created a pandemic. That H2N2 virus was evolutionarily more fit to circulate in humans and replaced that H1N1 virus into circulation with the pandemic of 1957. And then it circulated until, in turn, it was replaced by H3N2 that emerged in 1968. H3N2 continued to circulate, and then human populations became broad enough that they could support circulation of more than one influenza A subtype, and H1N1 reemerged in the population through possibilities that aren't fully understood, but reemerged back into the population. And since 77, we've had H3N2 and H1N1 influenza A viruses circulating together. That H1N1 virus then acquired additional gene segments from avian and swine sources to create the 2009 pandemic. And that's where we stand now with H1N1 and H3N2 continually circulating. So this is the process of evolution. Over time, pandemic viruses emerge, human populations adapt, they become less severe seasonally over time, usually. And now, we're at a stage where we can certainly anticipate future pandemics as well. Because of this, and there's reason to expect that the time period between pandemics will decrease as the world is increasingly crowded, connected, and converging. And while influenza seasonally may have taken a little bit of a break during the pandemic, that wasn't the case with avian influenza viruses. Avian influenza viruses with zoonotic potential continue to circulate, and in fact, have had more active seasons recently than perhaps ever in history. This is global avian influenza viruses with zoonotic potential detections occurring just in the last year, since October 2021. So it's been a very active season. There's a lot of H5 spreading across the United States, and you can see in Europe and Africa. So our vigilance needs to be higher now than it's ever been, as tired as we may be from the current pandemic. And the emergence of novel influenza A viruses in humans continues, and it's actually continuing at an unprecedented rate. You can see it's not just H5N1 that was very present with H9N2 earlier some years ago, but more recently, and also with increased surveillance and lab technology, we're seeing a variety of variants coming from swine sources, the presence of H7N9 and other influenza A zoonotic subtypes, all of which have pandemic potential in humans that we have to be ready for. How do we stay ready for that? We have to do rapid risk assessments of these viruses. When they're detected, we have to look at the characteristics of the virus, the characteristics of the population in which it's circulating, and what's its immunity, and how severe do we think that the virus can be, and the ecology of it, the global distribution, its infections in animals and human infections. So it takes multiple disciplines working together in a One Health coordinated way to detect viruses at the animal-human interface and to investigate them and to bring them forward for risk assessment. Standard risk assessment approaches, considering all of these criteria, are undertaken at WHO and at CDC, and viruses are characterized in terms of their likelihood of impact and their likelihood of emergence based on their genetic and epidemiologic characteristics. We take the ones that are at highest risk and we make vaccine candidate viruses to keep them in case there's a pandemic so that a vaccine can be quickly produced. And that's why you pharmacists and everyone else and the systems that you have for delivering seasonal viruses are also critical to this response, because it's right through those same mechanisms that these vaccines would need to come if one of these viruses were to emerge as a pandemic. We have the global influenza surveillance and response system globally that's working together to do this surveillance in both humans and animals, and to do these characterizations and to make sure the viruses are available for vaccine development, both in humans and for zoonotic viruses. And that's why this plays into the global influenza strategy from WHO that was mentioned in the introduction, where we're continuing to work on research and innovation to enhance surveillance and monitoring, to develop seasonal prevention and control policies and programs, looking at the most advanced technologies for treatment and vaccination, and to incorporate these into our pandemic preparedness and response. The outcome is to reduce seasonal burden, to minimize the risk of zoonotic influenza, and then hopefully to mitigate the impact of future pandemics. I know it was a lot and I went a little bit over, but thank you for your time. And I'd be very happy to take further questions. I'll just end by saying that the capacities that support monitoring, prevention, and control of seasonal and novel influenza enhance our pandemic influenza response capacities, and pharmacists are central in that. Thank you.
Thank you so very much, Dr. Mott, for this most interesting presentation. Actually, I think we are aware of that influenza is indeed of global concern, as well as the importance of seasonal influenza vaccination, as well as strategies. It is now my honor to introduce the next speaker. The next speaker today is Dr. Lynn Morgan. Dr. Morgan is Head of Global Public Affairs for Influenza and COVID vaccines at Sanofi Pasteur. And during her 8 years in public affairs, she has driven the company's policies on endemic diseases vaccines like yellow fever, rabies, cholera, dengue, and meningococcal infections with global healthcare stakeholders. She was the Sanofi Pasteur focal point for Gavi, the Vaccine Alliance, for including a tenure as board seat alternate when Sanofi Pasteur held the industry mandate at the Gavi board on behalf of the International Federation of Pharmaceutical Manufacturers and Associations, IFPMA. And she was also the Sanofi Pasteur focal point for IFPMA for 4 years, including 2 years as chair of the Vaccines Committee. Her focus is now on improvement of influenza policies and implementation. And prior to public affairs, Lynn held successive positions of responsibility within regulatory affairs at Sanofi, as well as at Sandoz and Astra. And she studied pharmacology at the Aberdeen University in the United Kingdom. Lynn, welcome to give us your presentation.
Narzaka, thank you very much. I'm absolutely delighted to be here today. So thank you very much to FIP for inviting me along. So I'm here on behalf of the influenza vaccine suppliers. So this is a group that was established back in 2002. And it groups together 15 manufacturers of influenza vaccine from around the world. So it's very much a global community. And they are the ones that produce most of the flu vaccines and run the R&D that's necessary to develop newer vaccines as you move forward and learn more about this disease, protecting against both seasonal and pandemic influenza. And this group IVS is housed within the Geneva-based trade association IFPMA that represents research-based pharmaceutical companies, as well as regional and national associations across the world. So IVS is actually quite a strong level of engagement, mainly based in Geneva. They work both on pandemic flu and on seasonal flu, and run several partnerships and really liaise often with WHO. So it was very interesting for me to listen to Joshua Mott's presentation. It was very, very interesting. So this talk's going to look at a little bit more downstream and how we're going to move forward, at least for the next year, in living with both seasonal and influenza and COVID. What does that actually mean for us? So next slide, please. About a year ago, I think I was sat in the same position and we were mulling over the fact that there was no more flu. Flu had disappeared, because if there was one thing we learned through the COVID pandemic was that flu could be very well controlled by non-pharmaceutical interventions. Clearly, however, there was a large social and economic cost linked to the broad use of NPI, social distancing, etc. And I'm pretty sure none of us would actually want to go through that every year. Fast forward to this time, 2022, and clearly influenza is back. So here we have a couple of observations on the Southern Hemisphere. We saw in Australia that country suffered from a big flu season. I remember seeing that observations from experts in Australia pointing out that it had been the worst May on record in terms of influenza cases, and they really appeared to go through the twin-demic that had been referred to as being a risk last year. And then for the US, they also went through a fairly atypical season with these two peaks there, and it was late with flu cases being seen right the way through June. And another kind of phenomenon that we saw was the interruption of other co-circulating viruses during the pandemic. One of them was RSV, respiratory syncytial virus, that seemed to be kind of appearing out of season in odd places when we wouldn't normally expect to be seeing it. So yeah, clearly influenza is back, and that's a worry for the reasons that we heard about from previous speakers on the threat that influenza poses to vulnerable people. So if you go to the next slide, please, let's ask the question, okay, and what is SARS-CoV-2 doing? There's a lot we don't know. We know it's still here, and as we head into the fourth dose in many countries, that obviously remains a reality for us all, but there's still a lot for us to understand about how this virus will evolve and settle into its patterns of circulation. Will outbreaks become seasonal? Will those seasons and potential possible future strain evolutions overlap with this seasonal influenza season? So how will those two fit together? Will it be the same case in the northern and southern hemispheres to match with flu in those two hemispheres? Or could seasonal patterns that we're seeing with flu be disrupted somehow by SARS-CoV-2 as it settles into its circulation? So quite a few questions there. What we do understand, and Josh referred to this also, is that we will have a challenge on uptake, on prioritization, on complacency, and we'll come to that, back to that point later. So on the next slide, please. Okay, so if we had a magic wand, what potentially could we want to see happening here? If indeed that concomitant circulation is here to stay. Well, I was at a congress in Ireland a couple of weeks ago, and there were several experts there that made reference to the future of combination vaccines and the real desire to have a bipathogen combo that would put flu and COVID in the same syringe, or maybe even a tripathogen vaccine with RSV and flu and COVID all in the same syringe. And then we'd get to one kind of big protective vaccination act at the beginning of the season. That would require a lot to happen. It would also mean managing strain changes in influenza, which is a reality for the reasons that we've understood very clearly from Josh from the previous season. We need to keep on top with what seasonal, from the previous presentation, we need to keep on top of what's happening with our the seasonal flu evolution throughout the year. It would also mean that such a combination would also mean achieving a very well-tolerated vaccine. If you think about how flu vaccines are right now, in general, very, very well tolerated. And that's key if you want to maintain your vaccine coverage rate. And we'll talk about a little bit about that later as well. So back to now, what we have right now is that we have in hand vaccines against flu. And at the tail end of the pandemic, we hope we have vaccines also to protect us against SARS-CoV-2. So we need to use the tools that we have in hand. And if you go to the next slide, we have vaccines. What's important to bear in mind is that vaccines only work if we manage to get the appropriate coverage. And in 2021 and 2022, where we had challenges around making sure that people kept flu vaccination top of mind and integrated COVID vaccination, we saw some exceptional measures being taken in order to reach the right kind of VCR targets that Lars Eickert referred to in the introduction. I put a little bit of a list here. I thought it would be worth pulling out 3 or 4 of them. One tool that was used was to extend the duration of the influenza vaccination campaign. So timing on flu is important. We don't want people to be vaccinated too early and see their immune response wane quickly, particularly in elderly people. Yesterday was the EU flu day, right? So that was a focal point for folks that are based in Europe to say, okay, the campaigns are starting in October, which is good. We don't really want to see campaigns starting in September because some of the frailer or more vulnerable populations may not be able to maintain the immune response right the way through to the peak of the flu season. Another point that we saw happening, which worked very well in getting to VCR targets, and I guess we're going to hear a little bit more about that from Portugal, was ensuring that there was access and co-administration policies in place, and that the pharmacist role was appropriately expanded. And we saw quite a few changes in law there that we'll come back to. Another point, the last point on that list that I thought was very interesting, was the use of real-time monitoring of vaccine status through apps. And I think if the reality is that we're going to see co-circulation of SARS-CoV-2 and influenza, and people have to start keeping track of what do they have, when, which vaccine, etc., I think we can really see a potential for the growth of the utility of having those kinds of apps. So I'm based in France, and on my phone I had an app that was able to tell me when I'd had my first dose, my second dose, when I was due to have a booster, which vaccine I'd received, where, etc. And that also allowed governments to have a view at a regional level and a national level in real time of the vaccination coverage rates. And I think we saw something similar in Australia with their system AIR. And why that is so interesting is that it allows a government to be able to course correct, to maybe to push out with a communication campaign. So that's the third bullet point here. And we did see that happening in Australia, where they saw that they weren't getting to the VCR that they wanted to with flu. So they launched a targeted communication campaign. They brought in some regional specific measures in Queensland, notably, to expand access to vaccine. So I honestly think that if we do have to juggle with these two pathogens moving forward, that this kind of closer understanding of what is happening will become pretty vital. If you move to the next slide, this one here just touches on how we get to optimal VCR in all of our target groups. So we heard about the people that are at much more risk of becoming severely ill due to influenza. And it's critical that we achieve that optimal VCR in those specific groups. Particularly as we move into this Northern Hemisphere, those are the people that we believe that will be of at particular risk because of the lower circulation that we have been seeing. If you move to the next slide, please. This slide here really underlines the critical role that pharmacists play and their almost responsibility, if I can say it that way, to making sure that we avoid any missed opportunities to protect those most vulnerable people, older people, people living with non-communicable diseases being particularly at risk here. And I guess when we think about having to live now with both of those pathogens circulating, the important thing is not having to choose between one or the other, which could actually be a significant risk. We know that that's not an option. Many health authorities have given out recommendations on co-administration of both flu and the COVID-19 boosters. There have been data generated that confirm that those vaccines given together result in a good immune response and that do not what's the word I'm looking for? I've lost my word. They also result in a good tolerability profile. So the safety aspects have been demonstrated in those clinical studies. That little map there that's on this slide shows the health authorities that have recommended actively the co-administration. Over and above that, WHO has also come out with their recommendation to give co-administration of the booster of COVID with other vaccines, including flu. And just also the day before yesterday, also as part of the launch of the flu season in Germany, I saw a very nice quote on Twitter from the German Minister of Health, who was talking about how important it was to launch this flu season and support it because it's flu and COVID. And he said, you know, double protection is smart. And I thought that was a very nice byline to have in mind as we move forward into this season. On the next slide, really underlining the importance of pharmacy-based immunization against influenza and the absolute key role that pharmacists play. That became hyper apparent during the pandemic, where community pharmacists were stepping up, you know, even more than before. And now, as we see vaccination centres that perhaps have been created for the pandemic will wind down or close, then your role will become even more important in discussing with people this co-administration with flu and COVID, building on that success and your position as a trusted healthcare point of contact. And managing that co-administration for me it's about avoiding those missed opportunities, as we said already, but it's also about allowing for flexibility. Some people might not want to get the vaccine at the same time. Not everybody will have that level of comfort. So managing that and making sure that, you know, people do feel that they can come back and get the second dose of either flu or COVID, depending on what they were able to get first time around. And I also really wanted to call out the very nice work that's been done with by FIP in providing materials to help pharmacists skill up in talking about that flu vaccination, to being in a very strong position to inform customers when they come in. And so there's a link here to one of the FIP webinars on the people who are most at risk on flu due to the fact that they're an older person or they have diabetes or are suffering from cardiovascular disease. Again, reiterating, you know, very important role that you have to play, and we have seen enormous growth. That graphic at the bottom on this slide here was really just a bit of a clip on where we were in 2016 with respect to pharmacy-based immunizations, which was part of the legislation in 20 countries, 2016. And if we fast forward to 2022, we now have 46 countries that allow for pharmacy-based immunization services, which has been a fantastic expansion. Just a couple of words then on complacency on the next slide. We have, you know, clear policies are clearly needed, and the mobilization of all stakeholders is key, be it at the health authority level, at the expert level, at the HCP level. Again, just calling out here that FIP has actually developed some very nice co-administration guidance. There was a webinar that they did on the 6th of September, and there's a link there to their library. Also, I wanted to call out, because it could be helpful depending on how your communities function, that rely also on the voice of civil society organizations or patient advocacy groups that you may be in contact with, because this question of what do we do, is it one or the other, is a recurring question. I'm sure we're all hearing it within our own entourage. It could be helpful to work with some of those groups in your own communities to make sure they're aware of the importance of the double immunization, and potentially get that information out to their own members, making sure they're on board and that they're informed. On the next slide, coming back to just again that point on complacency, we know that confusion, lack of clarity can feed into complacency, so always be clear on when, where, and how to get vaccinated with those 2 vaccines, and who is eligible to receive both. Very clear. They're hearing that message clearly from the pharmacists. People will feel a lot more comfortable about stepping forward and rolling up their sleeve. On the next slide, I wanted to have it's a little bit of a sidestep really, but I thought it was an interesting point to put to this group, because what we saw during the pandemic was this massive use of diagnostic kits and tests. I mean, everybody's had them at home. We went and bought them from our pharmacy. We took our test back in. We got vaccinated as in conjunction with our pharmacists, but we also got tested in conjunction with our pharmacists. So there's a different relationship has been created there. So we could also ask the question, well, is this going to be a new approach for understanding where we are with respect to respiratory infections in general? Will we go and get kits? Well, how are we going to live with that ready access that we had in the past, or is it going to be projected into the future? And so I discussed this with a colleague who's at Roche, and they've kind of looked at this particular topic more closely. And the US government actually ran a program called Test to Treat around COVID, where people would be tested and then potentially be treated with an antiviral through the pharmacy pathway. And so it's an interesting thought, and they listed out some opportunities and challenges here. I mean, it would be kind of interesting in terms of opportunity to be able to get your rapid diagnosis done if you have a respiratory infection that otherwise might not go diagnosed, and so you could be contaminating left, right, and center, transmitting to other people. It allows for rapid decision making on which antiviral treatment would be the best one for that individual, and obviously avoids delays if you go to your pharmacist rather than going through the traditional family doctor consultation, etc., etc. However, there are quite a few challenges raised as well. And if we just think about this within the US context, pharmacists remain restricted from prescribing those antivirals. So it can only go so far down the line and then they get stuck. So only very large pharmacies that are connected with a medical center would be able to act on the results of the diagnosis. And then there was also concerns voiced from the Medical Association that the approach would flaunt patient safety. And I think as well, from a more fundamental point of view, we have to wonder about how people would actually be able to get to the pharmacist if they're already feeling very ill. But at the same time, I think it's opening this whole door, and I'm sure it will not be closed too quickly on personal health care, and how people will actually want to understand when they start to feel ill. They will want to understand what it is they have, and they will want to get a cure because they've been exposed to this facilitated path on diagnostics. And I'm sure that the idea of take-home kits will grow and develop in the future. On my next slide, I really wanted to just spend a minute on a channel that I hope you might find interesting as pharmacists. It's called Together Against Flu. And it's an online campaign to keep awareness on the importance of flu vaccinations. And it could be particularly important right now as we head into this season. It's for people, you as pharmacists, healthcare workers, the importance of getting that flu vaccination message out there. It's an online campaign that uses some very interesting advocacy work from experts. So there have, a couple of them that you can see here. The middle picture is Jane Barrett, who's the Secretary General at the International Federation of Aging, who's very vocal on the importance of protecting older people with the tools that we have, so including vaccination, because of the effect of influenza leading to frailty, hospitalization, and some of those people that are hospitalized never actually find full autonomy again. And so that has obviously knock-on effects for the individual, for their family, for their quality of life. So this is really about equity of access to the right vaccination to make sure those older people are protected. So Jane is also on the editorial board for Together Against Flu. And so we have some interesting quotes from Jane throughout the season. And then the third picture down there on the right, and we refer to the impact of influenza on cardiac patients. So this is Dr. Alvaro Lepandri, who's from the World Heart Federation and who's a real advocate for the benefits of vaccination against influenza in order to reduce the risk of cardiovascular effects. And the World Heart Federation has been vocal on this. The European Society of Cardiology also referred to some of this information around those broader impacts of flu disease and their impact on myocardial and infarction and heart attacks. So Dr. Lepandri has been a great advocate. And so with respect to Together Against Flu, I would really encourage you to go and check out the site. You can follow them and get some boost as the season goes on with respect to what some of those experts are saying about flu. On my next slide, I'm just going to conclude pointing out that quote I mentioned earlier on: double protection is smart. This is the way we need to go as we head into the flu season. For people who are at risk of severe disease, please, let's not make it a choice between a flu vaccine and a COVID vaccine. We need to really literally double down our efforts and keep the most vulnerable people engaged and help prevent the preventable. Thank you very much for your time and for listening. My acknowledgements are on the last page. Thank you.
Thank you so very much, Lynn, for your interesting presentation. I would say that it shows that how important it is that both science, education, and healthcare and pharmacy practice collaborate. And we do have effective vaccines, and we need to use them. And the flu is back, and the pandemic is still going on. So, I mean, your final word, being double smart is very, very good. And we need to keep that in mind for the future. It's now my great honor to present the next speaker, Maria Mendez from Portugal. Mrs. Mendez is a pharmacist since 2011 and graduated from the Faculty of Pharmacy, University of Coimbra in Portugal, with experience in community pharmacy and hospital pharmacy. She is area manager of the Center of Medicines Information and Health Interventions at the Portuguese National Association of Pharmacies since September 2019. Her areas of responsibility encompass all issues relevant to public health interventions in the community pharmacy, namely development of new intervention methodologies and professional practice support tools, and the implementation of pharmaceutical intervention projects and pharmacy services support. Welcome, Maria, to share your experiences from Portugal.
Thank you very much for the introduction. And before I start, I would like to thank FIP for the organization of this important symposium and for the opportunity of being here to share with you the Portuguese experience in immunization service in community pharmacies. Next slide, please. As an agenda, I will start with some background information. Then I will share what we have done to support pharmacies in the implementation of the vaccination service. And finally, I will address some results as well as some barriers encountered. Next slide. As you probably know, Portugal is a small country with around 10 million inhabitants. We have around 3,000 pharmacies all over the country. And of these, about 94% are voluntary affiliated to the National Association of Pharmacies, ANF. We are very proud to have one of the most qualified pharmacies networks in Europe with an average of 3.9 pharmacies per pharmacy. Next, please. Vaccination service in Portuguese pharmacies was officially launched in 2007 when the Portuguese legislation extended pharmacies' rules by allowing the provision of immunization service. So since then, pharmacies are entitled to provide immunization services with vaccines that are not covered by the National Vaccination Program, which currently includes 15 different types of vaccines, such as the influenza vaccine, as well as the pneumococcal, hepatitis, among other vaccines. And next slide, please. On this chart, so you can see the list of the 17 vaccines that are not included in our national vaccination program. And it is important to refer, and maybe you know, that the yellow fever and typhoid fever vaccines are only available in the international vaccination centers. And I would also highlight that, of course, the influenza vaccine is included in our national vaccination program, but may be administered in the pharmacy for population groups out of the national program. Next, please. So back to 2007, as I told you, we got the permission to provide the service. So we have to build the capacity to do it. In order to do that, the ANF, the National Association of Pharmacies, developed a training program that was based on the American Pharmacists Association certificate training program, and it was also certified by the Portuguese Pharmaceutical Society. And back then, we also developed a specific intervention model and recommendation to support pharmacies in the provision of this new service. The first nationwide pharmacy-based immunization campaign against flu was launched in 2008, and since then, pharmacies promote the campaign on an annual basis. And currently, more than 2,500 Portuguese pharmacies are providing vaccination services, and more than 4,000 pharmacies, almost 5,000, are certified by the Portuguese Pharmaceutical Society to provide them. Next slide, please. Of course, to provide the service, pharmacies may fulfill some requirements, namely related to who can provide the service. And in Portugal, since the beginning, just the trained and qualified pharmacists by Portuguese Pharmaceutical Society are authorized to administer vaccines and injectable medicines in community pharmacies. Nurses could be also hired to perform this task in the pharmacies. In the pharmacy has an alternative. The Portuguese Pharmaceutical Society endorsed the specific training and specific guidelines establishing the minimal requirements for accreditation of initial training that includes a live training on injectable techniques, in addition to a certification on basic life support. To provide the service, pharmacies also have a mandatory recertification training each 5 years. Furthermore, pharmacies also have to have the infrastructures, of course, and all the equipments that are necessary and mandatory to provide the service, namely an adequate room, an adequate private room, all the materials to vaccinate in a proper and in a secure way, and also have to have the equipment to deal with anaphylactic events that fortunately is very rare. Next slide, please. Another important point are the vaccination records. Pharmacies in Portugal may register vaccine administration data on their pharmacy software. And in 2017, Portuguese pharmacies were recognized by the Health Ministry as an important vaccination point against flu, integrating automatically the vaccine administration record data from the pharmacy software system on the National Electronic Vaccination Bulletin. And this was, of course, an important step that reinforced the integration of pharmacies in the primary health care. Next slide, please. Last but definitely not least, we have the promotion of the service and the raising of public awareness on the importance of immunization. And in order to do that, the National Association developed several communication tools to help to promote flu vaccination in pharmacies, always aligned with the public health message. Next slide, please. As we all know, it is very important to monitoring our activity to collect and analyze data and to generate evidence. So on this chart, we can see the main results of flu vaccination service in Portuguese pharmacies in the last 14 years. It's been a long time. So in the flu season 2008-2009, the first year of vaccination service in Portuguese pharmacies, nearly 36% of all dispensed vaccines were administered in pharmacies. If you can make another click. And if you look at the last few seasons, we achieved the best estimated vaccination rate ever. 63% of all vaccines from pharmacy stock were dispensed and administered in pharmacies. It is a remarkable evolution. Next slide, please. Another click, sorry. In 2012-2013, due to the reduction of number of vaccines available for pharmacies and also due to the implementation of free immunization of elderly people in public services, there was a reduction on overall number of vaccines and vaccinations in pharmacies. And another click. Yeah, and I also highlight the year 2018, considering that for the first time, pharmacies were invited to collaborate as National Health Service vaccination points. So at the time, a pilot project was carrying out in 39 pharmacies in a region near Lisbon. Within the scope of this pilot, elderly patients were able to be vaccinated against influenza in pharmacies under the same terms as in NHS primary care units. So elderly did not need a prescription, and there was no administration fee nor payment for the vaccine. The aim of this pilot was to increase influenza vaccination coverage in elderly people by improving their access to the vaccine through the contributions of community pharmacies. And due to the good results of this pilot, in the following years, pharmacies were again challenged to participate as an NHS vaccination point. So we consider that the impact of the pharmacy intervention has been recognized by the National Health Service, and we continue to collaborate within the scope of the needs defined by the health authorities. Next slide, please. For this flu season and following our experience in previous years, the Ministry of Health made available around 20,000 vaccines from the NHS stock for free vaccination of people over 6 months and under 65 years of age with chronic diseases, provided if they present an electronic medical declaration issued through our medical electronic prescription platform. In a more structuring and relevant way, pharmacies will also contribute with more than 850,000 vaccines from their private stock to vaccinate the Portuguese population in this flu season. Next slide, please. The Portuguese experience has been disseminated through oral communications and posters at congresses, also published articles and also in FIP reports. So if you have the curiosity, you can check if you want it. Next slide, please. But of course, over these 14 years, we have faced several barriers. In this slide, I have listed some of them. of which I would like to highlight the unequal and unfair conditions for patients that prefer pharmacies. I mean, in Portugal, we have free vaccination at public health centers and in primary care units, but in pharmacy, we continue to have a patient co-payment. For example, for flu vaccine, we only have a 37% reimbursement of the full price of the vaccine, and the people also need to pay vaccination service fee at the pharmacy that is freely established for each pharmacy. And we have also faced some vaccine shortages, and unfortunately, sometimes we have assisted to a lack of coordination between public services and pharmacies. And we have the old problem of lack of data sharing between pharmacies and public health services. Next slide, please. As closing remarks, I would like to highlight that there's a consistent increase in the number of pharmacies involved in vaccinations. As I said before, nowadays, more than 80% of Portuguese pharmacies are involved in vaccinations, and there are almost 5,000 now qualified pharmacists available to vaccinate. I would also highlight that a significant number of patients prefer pharmacies over public services despite uneven conditions. And we are very proud to say that since 2007, more than 3.9 million of people have been vaccinated against flu in Portuguese pharmacies. And in addition to flu vaccine, pharmacies administer all vaccines not included in our national vaccination program. But unfortunately, pharmacies are not allowed to administer COVID-19 vaccines, despite having expressed to the Ministry of Health availability to participate in vaccination process. Next slide, please. Furthermore, evidence shows that pharmacies are available research in healthcare system with trust from the population, and immunization in pharmacy add value to healthcare and promotes broader coverage of population. In the Portuguese case, we consider that the value of the contribution of pharmacies in vaccination has been increasingly recognized by the NHS, and we believe that it represents gain for all parties involved. It would be beneficial for the country to create the conditions of equality in vaccination between pharmacy and public health centers, providing efficiency and also freedom of choice that would, for instance, avoid peaks and constraints in responses. Next slide, please. So if you need any more detailed information, please feel free to address me questions on the Q&A or send me an email, and I will reply it in due course. Thank you very much for your attention.
Thank you, Maria, for your very interesting presentation, where you actually highlighted the value of pharmacy as a vaccination center, and also, I would say, most impressive results and most impressive development of pharmacy and pharmacists as vaccinators in Portugal. And I also think there are lots of evidence showing that you can actually or have reached a higher number of patients at risk than within the traditional healthcare system. So excellent. Thank you so very much. And I'd also like how pharmacy is part of national public health campaigns. I think that's very important. I would like to welcome all the speakers to a panel discussion. So please turn on your cameras. It's time for the Q&A session or part of this event. First, I would like to ask Lynn, is the impact of the seasonal influenza the same in both hemispheres, or is there a difference between the two parts of the world?
For me, the impact is the same in terms of the disease that can be caused to individuals. In terms of the actual virological number, the virological circulation rates in northern and southern, I'll let Josh perhaps give the expert response on that. But certainly as a manufacturer, we make vaccines for both northern and southern hemispheres because we understand the need for vaccines in both, and the fact that individuals who are at risk do need protecting regardless of where they live.
Josh, would you like to comment upon this?
Sure, I think that was a good answer. One thing we know about influenza is if you've seen one influenza season, you've seen one influenza season. And the season may not be the same from the southern hemisphere to the northern hemisphere. I will say that overall, the impact of influenza is as important in each hemisphere, though individual seasons and the severity of them may vary from one to the other in any given year.
Okay, thank you so very much. We have a question here from Bafa El Tayeb asking, are there any sequencing studies screening for the possibility of insertion of SARS-CoV-2 genes in other RNA viruses coincidentally present in individuals, especially if vaccinated with the mRNA SARS-CoV-2 vaccine? Who can answer this question? Josh?
I'm not a virologist, so I mean, the extent to which you can insert genes from one virus into another is not something I think I would want to venture into trying to answer.
Okay. Lynn, do you have?
No, reading it sounds unlikely, but I don't have the data to back that up. So, yeah.
No, but we can perhaps look into it and afterwards.
Because maybe the question is about making a combination vaccine with an mRNA vaccine that contains the genes of both flu and SARS-CoV-2. I'm not sure if that's what the question was, but I think a combination would be an mRNA vaccine, again, containing the sequences for flu, and then another mRNA vaccine, or flus, because there will be several, and then another mRNA vaccine, which would be containing the appropriate sequences for the relevant strains of COVID that we'd want to protect against. I'd see it more as several vaccines all being packaged together, if that's what the question was. But
yes. Okay, thank you so very much. Maria, how does the training program that pharmacists have to carry out works? Is it mandatory to provide the service in the pharmacy, or can a pharmacy choose whether they would like to do it or not?
As I told in my presentation, in Portugal, only certified pharmacies by the Portuguese Pharmaceutical Society can perform the service in the community pharmacies. Also, and as an alternative, we can hire nurses to do that. So, for instance, pharmacy technicians are not allowed to provide the service. And basically, the training program, it's a long training program defined by the Pharmaceutical Society. And the objective of this training program is that the pharmacist could get all the knowledge needed to provide a high quality service in the pharmacy. So pharmacists must study the basic fundamentals of immunology, all the characteristics of all vaccines, and of course, we have a live training for the injection techniques, of course. So the course takes about 28 hours. 20 study hours and plus 8 practical hours. The National Association provides the service and also the Pharmaceutical Society.
Thank you so very, very much. Josh,
sorry,
yes,
sorry, Lars, I forgot to answer the question. Is it mandatory to the pharmacy to perform No, it's optional. So the pharmacist could or not perform the service. It's up to them.
I understand. Thank you.
Thank you.
Joshua, for a low and middle income country that has limited resources, how should they start an influenza vaccination program?
That's a great question. I think you need to start at what is feasible. One population that has been of growing interest to at least start with and get the program operations moving, and also have the dual benefit of pandemic preparedness, is healthcare providers. Vaccination of healthcare providers is important because in countries with limited resources, it's often a finite population. You know where to reach them. And there's the added benefit that you can influence their attitudes about vaccination to those that they're treating. They're also very important for pandemic preparedness. So many countries are increasingly thinking about healthcare providers as a foot in the door. And then from there, you have to look at your most impacted groups and those that you can most reasonably reach with the available amount of vaccines and funding available. That might be pregnant women, or it might be the elderly, although there's often very many more of those. But then it kind of depends on the country resources.
Thank you.
Lars,
yes, Lynn, yes.
Sorry, I just wanted to add in, there's a for the folks that are asking this question, there's a very interesting organization called PIVI, so the Partnership for Influenza Vaccine Introduction, that specializes in finding the right way to bring vaccines into LMICs. So it can be through technical support and or vaccination financing. And as Josh says, they target so that the right population for a fit with that country. So it could be healthcare workers, it could be specifically a specific population amongst the pregnant women, for example, or a sub-cohort of pregnant women. So for the person that asked that question, do look up PIVI, and look into it, because they have a very nice methodology.
Thank you. Actually, I have another question for you, Lynn. When it comes to the flu vaccines, they comprise 2A and 2B strains, and there is considerably less circulation of the B strain in the past couple of years. What does this mean for the policy of recommendations when it comes to the current quadrivalent vaccines?
Yeah, thanks. That's a good question. And I think, Josh, you referred to this in your presentation with a little question mark, because on the second B, the B Yamagata, there's been very little seen. And I think that's what's so fascinating about the natural history of viruses and how they can impact one another. And it's true, we've seen a lot less. It doesn't mean, however, that we backtrack, if you can call it that way, to a trivalent vaccine. A lot of effort was made to introduce another B strain, because we could see they were circulating and it was causing disease. So for the moment, it's certainly too early to say that this Yamagata strain is extinct. It's not circulating very much, but it may re-emerge, or it may be replaced by another B strain that could emerge on its own. So for the moment, QIV stays QIV. That stays the standard of care, and we'll see what happens over the coming years. I know that some of the experts that Josh referred to, like the surveillance system, GISRIS, are looking at doing more detailed analyses of those circulating B strains to work out really what's going on. And we'll know more at the end of this current Northern Hemisphere season exactly what's been happening.
Okay, I was thinking when it comes to the Gavi initiative, etc., we saw that when it concerned COVID-19 vaccines, there was you can say an uneven distribution around the world, where some countries actually didn't have any vaccines and others had almost too much. When it comes to the flu vaccines, is there an even distribution worldwide, would you say?
There's definitely not an even distribution worldwide. There's not an even demand worldwide. I think we have to be quite pragmatic when we think about where seasonal vaccines are used. It's often a question of priority. I'm not saying it should be that way, but I think often in LMICs, there are other diseases that come higher up in the priority. But we do believe that there should be more advocacy around using seasonal flu in the right place. We're not saying that it should be used everywhere, but within targeted populations, it should be something that is prioritized. Josh mentioned healthcare workers, for example. Yes, protect those people from getting flu, and also start to have that conversation about adults being vaccinated, because as we've seen with many LMICs, part of the problem was the vaccination. Adults are not used to being vaccinated, and therefore there was a lot of one of the reasons for a lot of hesitancy about stepping up as an adult to be vaccinated with a COVID vaccine once those vaccines became available. To your specific point on Gavi, they did have an initiative a few years ago to introduce healthcare worker vaccination with flu, and those plans fell apart with the pandemic, but it was at one point a part of their strategy.
Okay, thank you so very much. Joshua, do you think this is linked to sort of the efforts of the countries, how they actually try or not try to update the planning for a future influenza pandemic?
100%. This type of vaccination planning and the use of a seasonal influenza program that has benefits year in and year out should be a key component of what countries are thinking about for their future pandemic preparedness every year. Did that answer your question? Sorry.
Yes, okay. Yes, I think so, yes. But also linked to the fantastic experience from Portugal presented by Maria, would you say that the WHO actually from now on can recommend countries to use the pharmacy workforce in their vaccination strategies and campaigns?
Well, I think so, and I hope so, yeah. Because I think we have a great experience and a lot of evidence. We wrote a lot of evidence. We produced a lot of evidence. So I hope they can use it to expand the service in more countries, to community pharmacies. I hope that.
Yes, we are more than 4 million pharmacists worldwide, ready to step up and take on this challenge to support a healthier life for every person and every nation. What are your thoughts, Joshua? Do you see pharmacy as a potential workforce in vaccination strategies?
I think they can be a terrific workforce. Every country has its own policies about the roles that pharmacists can and cannot play. I think it's an important point for advocacy. I think we need to take the lessons from the countries that have integrated them and broadcast those and continue to keep this public health component of pharmacy work in their training programs.
Thank you so very much. Let's see if we have any more questions from our participants. I don't see any more questions at the moment. I think they have been answered also online. So if you have any more questions, please send them now. And if there are no more questions, actually time is also running out. I would like to thank all our speakers for their fantastic presentations, for sharing your knowledge, your expertise and your wisdom. And also thank you to all of you online for attending today's symposium. It has been great to have you all with us. And I think some concluding remarks can be that a flu shot can actually save our lives. And the flu shot helps us with herd immunity, and most people are eligible for getting a flu shot. And of course, the flu shot changes each year due to the mutation that we have heard of. And you can't get the flu from a flu shot. It's a protection. And vaccines are key to a healthier future. And vaccines are also a major public health tool. And double protection against the flu and the COVID-19 is really, really smart. And we need all to work together in fighting the flu and in fighting other pandemics. So together we are stronger. And of course, pharmacy is the most accessible healthcare provider. We should follow the Portuguese example. So thank you also very, very much, our speakers and you attending online, for being with us today. This is a very important seminar, a very important symposium, and we need to fight this together in the future. Thank you so very, very much. So I think that is okay. You can get to the next slide as well. And the next one. So try to use the preventive measures and protect yourself, get the flu shot. Thank you so very much, and stay tuned to the FIP.org for future digital events. Thank you and goodbye.
Thank you. Bye-bye.
Bye.
Thank you all.